So I'm hopeful this will go well, and I hope you learned something about drooling today. Let's see if I can making sure I can. There we go. So the objectives for the talk that I'll be giving you are to discuss factors associated with drooling in Parkinson's, to describe possible causes of drooling in Parkinson's, to review how drooling affects the lives of people with Parkinson's, and to finally provide some management options for drooling in Parkinson's if it is an issue. So just to speak first about the normal physiology, or the normal way that we salivate and swallow, we have three sets of salivary glands on each side of our face: the parotid, the submandibular, and the sublingual. The sublingual is located under the tongue, the submandibular just under the jaw, and then the parotid gland is located just in front of the ear on each side. I should mention, the salivary glands are controlled by the autonomic nervous system. The autonomic nervous system is the sympathetic and parasympathetic systems that control automatic function in the body. With respect to salivation, we get our stimulus to salivate through the parasympathetic system, which is your rest and relax system. So when you're resting and eating, you may salivate, whereas the sympathetic system, which is your fight and flight response system, when you're nervous and anxious, typically people don't salivate much. Their mouth actually goes dry. So it's more of a parasympathetic response to salivate. With respect to swallowing, there are a number of phases to swallowing. The first is the oral phase, and this is when food or liquids are in your mouth. This is a voluntary part of the swallowing mechanism, so you have control over this. This is where you use your teeth and your tongue to guide the food or liquid to the back of the throat, which is called the pharynx. In the pharyngeal phase, this is an involuntary part where there's about 30 muscles that are used to coordinate and time the movement of the food or the liquid down into the esophagus. And the esophageal phase, that starts off with the upper esophageal sphincter opening to allowing food to go down the esophagus. The food or liquid moves down the esophagus by peristalsis, or sort of wave-like movements that push the food down. And then the food moves through the lower esophageal sphincter and ends up in the stomach. Drooling is generally defined as excessive pooling and poor control of saliva in the mouth. So, for example, in babies who don't have very good control of their mouth, they frequently drool. Sometimes the word drooling is used synonymously with the word sialorrhea. And I think that it's so common these days that we often just use them interchangeably, but they actually have a little bit of a different meaning. And sialorrhea is typically when people have an overproduction of saliva that leads to drooling. So whereas drooling is just the saliva in the mouth and pooling and maybe coming out the front, sialorrhea is when you're producing too much saliva in your salivary glands. There are many different neurological disorders that can be associated with drooling. Today we're talking about Parkinson's disease, but some of the other Parkinsonian conditions, including multiple system atrophy, progressive supranuclear palsy, dementia with Lewy bodies, and cortical basal degeneration, may all have drooling as a significant symptom. Drooling can also be seen in muscular disorders that are kind of neurological in basis, including amyotrophic lateral sclerosis, also known as ALS or Lou Gehrig's disease, and muscular dystrophies, which there's a lot of them out there where the muscles become weak. I'm sure you are all very familiar with the motor symptoms of Parkinson's disease. This is just a list of some of them, probably not all of them, but I'm sure you're aware of the resting tremor that can occur in Parkinson's disease in many people who have Parkinson's, but not everybody. Rigidity is the stiffness of the limbs that develops in Parkinson's. People with Parkinson's can develop a reduction in their facial expression, which is called a masked face. They develop slowness of movement, which we call bradykinesia. Oftentimes arm swing is reduced, and this is often, like other symptoms, asymmetric, where one side seems to be reduced more than the other, and this can end up leading to shoulder discomfort and balance issues. And postural instability, which is the sense of imbalance that people have as Parkinson's progresses typically. A stooped posture. Retropulsion is the tendency of people with Parkinson's to fall backwards when they're tugged backwards. Quiet speech, which is called hypophonia, trouble swallowing, which is called dysphagia, and small, sometimes messy, difficult to read handwriting, which we describe as micrographia. You probably also know that there are numerous non-motor symptoms in Parkinson's disease as well. These were largely ignored for a long time, and most researchers and clinicians focused predominantly on the motor symptoms. But we now know that there are many non-motor symptoms that impact quality of life and functioning just as much, if not more, than motor symptoms. And they've really grown over the past 10 to 15 years in the scientific literature. So people are researching these issues more and more and attempting to find adequate treatments for them. They include sensory symptoms like numbness and pain and cramping, mood disorders like anxiety and depression and apathy, hallucinations, which are often visual, and how we describe them as well-formed or very lifelike hallucinations, although sometimes people just get a sense of someone walking behind them or someone in the room with them. Cognitive dysfunction and dementia, so problems with thinking and memory, are seen in Parkinson's in some people. Disorders of sleep-wake regulation, and the most common one to mention here is probably REM, sleep behavior disorder, where some people with Parkinson's disease act out dreams at night when they're sleeping. And then finally, autonomic dysfunction. And so this is when the parasympathetic and the sympathetic nervous systems aren't working properly. And people can develop issues with their blood pressure, particularly when they stand up. They may notice that their blood pressure drops. Problems with their bladder function, and problems with constipation. And in men, erectile dysfunction is often seen. So drooling in Parkinson's, back to that. There's a bit of contention, it seems, as to whether drooling is considered a motor symptom or a non-motor symptom. And depending on what you read, you'll see it under both categories. I think people think it's a non-motor symptom because salivation, as I've discussed, is related to the autonomic nervous system, the parasympathetic and the sympathetic nervous systems. But as you will see as I progress through this presentation, there is an argument for it to being a motor symptom as well. So how common is drooling? Depending on what paper you read, it seems that it's observed in between 10 and 84% of patients. One study that I was reading the other day found that about 55% of those who complain about drooling are in an early stage, 33% are in a mid stage, and 11% are in an advanced stage of their illness. Now, this may not really be accurate though, because sometimes in advanced stages, other issues are so prominent that people are struggling in other ways that they may not mention drooling, as compared to in early stages where they're doing very well, and this may be something that they notice or more bothered by because of that. Depending on the study that you read, you may also find that it may say that men have drooling more frequently than women, or men and women are equal. So I think that the jury's a bit out on whether or not there's a tendency for men to be more affected. It's often mild, so drooling in the studies that are being done, most people who drool state that it's only a mild issue for them, or it may only be present at night. And I find this is my experience too. This is a question I always ask my patients when I first meet them, and I try to do it intermittently after that. And a lot of people do say, oh yeah, I notice a little bit at the corners of my mouth at times, or I notice drool on my pillow, but it's not that frequent that people state that it's a major issue. The time from diagnosis to treatment is approximately a year in the literature. And this makes sense to me. I find a lot of people, the first time we discuss drooling, they kind of want to know what their options are, but sometimes people just aren't ready to make a commitment to try a medication or another treatment for drooling. And it may only be after some more thought and recognizing how much drooling is impacting their life that they may then proceed with treatment. So there are a number of different factors that have been associated with drooling and Parkinson's disease. It seems that the longer someone has Parkinson's, the more likely they are to have drooling. It also seems that the severity of the motor symptoms, stiffness and slowness and tremor, for example, the more likely someone is to have drooling. And this may not necessarily be related to disease duration. Someone who has relatively early Parkinson's but has never been treated for their Parkinson's may have more severe motor symptoms than someone who's in mid or later stage but is going through, but is very well treated for their symptoms. So someone early in that case may have more drooling than someone later on. Swallowing difficulties. There seems to be quite a significant association between trouble swallowing and drooling, and this makes sense. If your swallowing mechanisms aren't working properly, saliva may not go down normally. There's an association between reduced facial expression and drooling. People with Parkinson's, they often lose their, well, not lose, sorry, they have a reduction in their frequency of blinking. And they also have slowness and a reduction in the movement of the lower face as well. And over time, people with Parkinson's keep their mouth open more frequently. And this lack of movement seems to predispose people to having an accumulation of saliva in the mouth. There's also an association with speech. So if people have quiet speech, it typically indicates that there's some slowness of movement and possibly stiffness in the face that's impacting the speech. And again, this can impact their ability to swallow regularly, and they may accumulate saliva too. There seems to be an association between history of antidepressant use and drooling in Parkinson's. And I don't think that the people who found this in their paper identified why, and I don't know either. This is not related to disease duration, because a lot of people with early Parkinson's disease suffer from anxiety and depression and are on treatment for that. So I'm not honestly clear why there would be an association between the two, but it's useful to know, because if someone's on antidepressants, I should know myself that it may be something to ask about more regularly. There are some other factors, including dementia. So people who have dementia seem to have more likelihood of drooling, and this maybe impact how long they've had the illness, because dementia is usually something that happens in some individuals over many years of Parkinson's. Hallucinations are also associated, and hallucinations also typically occur as the disease progresses, and it's related to disease duration. And finally, orthostatic hypotension is the tendency of the blood pressure to fall when you stand up or sit up. And this is also typically a symptom related to advanced Parkinson's, and therefore it suggests that it's related to how long someone's had Parkinson's, and how that's related to drooling. There are a couple of factors that they looked into, researchers, but they did not find an association. One is the age of onset of Parkinson's disease. So whether you develop Parkinson's in your 30s or in your 70s, there's no difference in the likelihood you'll get to any drooling. And then your levodopa dose. Now, some people would say that your levodopa dose is somewhat related to how long you've had Parkinson's, but not completely. And I certainly have people in my practice who have not had Parkinson's for long and are on high doses, and people who've had Parkinson's for quite a long time and have always been on very low doses. And that doesn't seem to be related to drooling, what dose of levodopa people are taking. So causes of drooling in Parkinson's disease. One of the major causes is impaired salivary clearance. So this is the ability of a person to remove saliva from their mouth. And there are a number of factors that contribute to this. The first is poor tongue movement, or tongue bradykinesia. When I first meet my patients and assess them with a physical exam, I typically have them move their tongue quickly from side to side. And it's one of the first indicators to me about whether they have Parkinson's, because people with Parkinson's often have more slowed movements. So the tongue can be affected. And this obviously can contribute to the ability of the tongue to push liquids, including saliva, to the back of the throat for swallowing. Sometimes it's the whole mechanism within the oropharynx, or the mouth and throat, so that the muscles in this area become slow and don't work in the right sequence, and so people have difficulty with swallowing, and this includes saliva. And then finally, the upper esophagus, the muscles in this area also are impacted in Parkinson's and can slow down and become uncoordinated, and this can impact swallowing and drooling as well. The severity of swallowing difficulties is associated with the severity of drooling. So when individuals who have very severe swallowing issues, the next question I should always ask, and that people should think about, is there drooling? Because they're so linked, and that's can be a quality of life or functional issue. Another cause of drooling is an inability to maintain saliva in the mouth. So there are a number of factors that are related to this. The first is stooped posture. As you know, people with Parkinson's often lean forward. And if you're leaning forward, gravity would naturally try to remove saliva from your mouth through the front. So this may be a reason why people are drooling, because they're leaning forward so much. The reduced facial expression that we spoke about earlier, or hypomimia, people tend to have their mouth open for periods of the day, and this worsens over time. And if your mouth is open, it's more likely that some saliva will seep through. Finally, mouth breathing and unintentional mouth opening. So this seems somewhat linked to the second point there, but people with Parkinson's sometimes mouth bleed, and this may be related to congestion of the nose or other issues, and then this may in turn lead to drooling out the front as well. When I talk to people about drooling, one of the immediate assumptions is that people who drool have more saliva. And really, this was hypothesized initially in the research communities as well. And what they found that people with Parkinson's generally do not produce more saliva than anyone else. And in fact, they may produce less saliva. It's thought that there may be a role for dopamine in the production of saliva. And because people with Parkinson's may have dopamine deficiency, they may have less saliva production than others. So it's not because they're producing more saliva, it's just that they're not clearing it from their mouth in a normal way. So it's not, so when they're eating, this is my attempt to say, when they're eating and they're not drooling more than other people. So how does drooling impact life? So the first thing to discuss briefly is quality of life. And there are researchers assessing how every symptom in Parkinson's assesses quality of life. And they've tried to look at drooling too. It's been really challenging, I understand, to get a good sense of how drooling affects quality of life in the form of studies. And this may be because of what I mentioned earlier, that most people have mild or just nighttime drooling. And if that's the case, oftentimes people aren't particularly bothered by it. And so I think it's hard to get a large enough group of people who have bothersome, severe, or at least moderate drooling in a study to assess quality of life. So I don't think that the population of patients that are being looked at are necessarily the people who may be bothered. And I find that in my practice, although many people have drooling and are not bothered, I absolutely have many people in my practice who are immensely bothered by their drooling for various reasons. So one of the negative aspects of drooling is its impact on breath. If you have saliva accumulating in the mouth, it often gets smelly, and people who drool a lot and who have a lot of saliva in their mouth can get bad breath, and that's embarrassing and impacts their social interactions. If you have a lot of pooling of saliva in the mouth, it can impact oral hygiene. There are a lot of bacteria and sugars in saliva, and if you're not clearing them regularly from their mouth, they can impact the teeth and cause problems with cavities and tooth decay in general. Some people with drooling, because they drool so much, they get almost a rash or skin irritation where the drool is located. So I don't see this very often, but absolutely drool can be irritating to the skin and cause perioral dermatitis as a cause. People who drool may notice an impact on their eating. They may not be able to chew and taste food properly because of how much saliva is in their mouth. so it may impact their ability to eat successfully and in a tidy way. This is something that I've noticed in my practice. Excess saliva in their mouth and drooling may impact how much of your medication actually gets down your throat and into your gut. So I have had a number of patients in my practice complain that their drool is always yellow because it has some of the levodopa in it. And so rather than getting that levodopa in their gut and getting a good effect from that medication, they're drooling out that medication because it's just joining the saliva. So I do think that in some people it can affect the extent of the medication's effect. It makes sense that drooling and just excess saliva in the mouth can impact speech, and some people find that their speech is gargly and difficult to understand because of drooling. One of the big things with drooling is that it's socially embarrassing for people. Some people don't want to interact outside of their family because they're embarrassed about drooling, and it's emotionally distressing related to this. So this is, I find, a significant factor for people who complain of drooling. One major issue with accumulation of saliva in the mouth is that bacteria can start to build up in the mouth because it builds up in the drool, and because of this, people then can aspirate or have saliva go into their lungs, and this can lead to a pneumonia. And so there seems to be an association between people who drool and the likelihood of developing pneumonia. And as you may know, pneumonia is one of the primary causes of death in Parkinson's disease, and it's something that we see not uncommonly. Not only does drooling impact patients, but it impacts their caregivers, impacts the burden on the caregiver to kind of wipe their loved one and also clean up after the loved one with respect to their clothes and other cloths and tissues. It can impact, cause depression and anxiety in caregivers and reduce quality of life in caregivers as well. So an assessment of drooling, there are a number of different ways we can do this. One is subjective or self-reported questionnaires. Excuse me. There are a number of questionnaires and just different general questions that have been arranged to ask about drooling. The UPDRS is the Unified Parkinson's Disease Rating Scale, and this is something that I use regularly in my practice, and most movement disorder specialists and researchers use it. It involves many questions about motor and non-motor symptoms in Parkinson's, and then one aspect of it is the physical exam that we do for Parkinson's disease. But one of the questions of this scale is a salivation question. And I would generally ask people about whether they're noticing any excess salivation. If they say, oh, no, it's normal, they get a 0. If they notice a slight but definite excess of saliva in the mouth and maybe have nighttime drooling, they get a score of 1. If they notice moderately excessive saliva with a minor amount of drooling, they get a 2. A marked excess with some drooling is a 3. And if they have marked drooling requiring a constant tissue or handkerchief, they get a score of 4. There have been some other scales developed just to look at drooling, including the Drooling Severity and Frequency Scale, the Drooling Rating Scale, and the Salivation Clinical Scale for Parkinson's. And one doesn't seem to be better than any others, and so you'll find all of them used in the research on drooling and Parkinson's. This is just one example of one of the other scales. This is the Drooling Severity and Frequency Scale, and it's divided into severity and frequency. So people are asked to rate the severity of their drool and also the frequency of their drool, and their score is calculated, and that is followed over time. There are more objective measurements that have been developed to try to measure drooling, and this seems a bit challenging actually. There's no definitive test that is done. I think most studies use more the subjective self-reported scales, but there's been a few studies that have used these objective measurements, and they're used to measure the volume of saliva and salivary flow. One method are sponges and dental rolls that are placed in the mouth. So this little picture here is an example of the dental rolls, and it's my understanding that they place them in the mouth, then they weigh them, and they can measure how much saliva a person is producing, and they can kind of measure it before and after the use of a treatment, for example. Some studies measure the weight of bibs that patients are wearing or the number of bib changes that are required during a day. So the real reason for the talk here is the management of drooling and Parkinson's, and I'm going to give you some details about this today as well. The first thing to do, if you can, is to remove medications that may aggravate drooling. So the class of medication called cholinesterase inhibitors are medications used for memory and thinking. These include donepezil, also called Aricept, galantamine and rivastigmine, called Exelon, and my mind's kind of actually blanking about the third one, the third trade name, but these are not uncommonly used in advanced Parkinson's disease, but they occasionally aggravate drooling. And so if someone is on one of these medications, it's worth questioning whether they had more drooling, or they had drooling before they started it, or if it's something that happened after. And if it's not really doing any good, there may be a rationale for stopping this medication. Clozapine is an antipsychotic medication that is used in rare individuals with Parkinson's. Clozapine is a bit tricky to use because you have to have regular blood monitoring for your white blood cell count, and so it's not used often. But in people who have very severe dyskinesia or a very severe tremor, or hallucinations that haven't responded to quetiapine, clozapine can be very helpful. So it can be used, but it can aggravate drooling. Antipsychotics in general can aggravate drooling, and quetiapine is the more classical antipsychotic that we use in Parkinson's to help with hallucinations, and that occasionally worsens drooling as well. Always have to balance if the benefits outweigh the adverse effects, and typically when we're using quetiapine, it's because we really need to manage hallucinations, which are distressing for a person. And so I don't think it's honestly all that common in my practice that I would that we would stop quetiapine if someone's having drooling, because usually they really need it if they're on it. And but it's something to consider, and there are people who just use it for sleep, for example, and that may be a rationale for stopping it in those cases. Another step in management of drooling is to improve or optimize the control of Parkinson's motor symptoms. So like I mentioned earlier, slowness of movement, facial masking or lack of facial expression can be factors contributing to drooling. And if you have someone move more normally, you may find that their swallowing improves and their facial expression improves and their drooling reduces. So one option is to ensure that people are adequately managed, and for patients it may be useful to adjust the Parkinson's medication, so increase levodopa, change the timing of levodopa, or add other medications such as dopamine agonists, entacapone, or selegiline. There is one study that suggests that for the rotigotine patch, which is one of the dopamine agonists available, that may actually reduce drooling. So there was a study published recently that questions whether a small dose of this may impact drooling positively. So there are different options with the Parkinson's medication. And then also it seems that surgical therapies for Parkinson's, such as deep brain stimulation, may also improve drooling for some people. So obviously no one would go for surgery because of drooling, but if they're a good candidate for surgery because of problems with their movement symptoms and problems with the medication or side effects of medication, this may be something that also benefits some people with Parkinson's. It may be worthwhile trying some behavioral techniques for encouraging swallowing. So a lot of people with Parkinson's don't swallow frequently enough, and it's hard to really remember to swallow. We typically don't think about it consciously on a regular basis, but there have been a couple of things developed to help people remind themselves to swallow. You may notice the picture with the woman's chest and a little button on her coat. that is a little sound that goes off to remind that person to swallow. So you can get these types of devices that make a sound to have you swallow at a certain frequency. This day and age, there are also applications for smartphones. This is one example. There's a swallowing prompt application where you can set the frequency of the prompts to how often you think you should be swallowing, and also how they let you know, is it a vibration, is it a certain tone that allows you to get the sense, get the recognition that it's time to swallow. So for a technologically savvy person, a smartphone app may be a good option. Medication-wise, there are a number of different medications that are used to try to help with drooling. One of the most common that I use in my practice is atropine. Atropine is a liquid, and you take it as a drop under the tongue. How it's usually prescribed is the 1% atropine drops, 1 to 2 drops under the tongue, up to 4 times per day. I find that some people are very happy with this medication, and they find it makes a huge difference to the amount of drooling. Atropine drops the parasympathetic, blocks the parasympathetic nervous system, so it reduces the amount of saliva produced by the salivary glands. Ipratropium bromide is Atrovent, which is a spray sometimes used for respiratory issues, but the spray is actually anticholinergic as well, and so it blocks acetylcholine, so it blocks the parasympathetic system again and reduces drooling. In my personal experience, I have not found my patients to be as happy with Atrovent as with atropine, and I still try it. I think the spray is a nice option for people, and there's evidence that it may work, but I just, in my personal practice, I just haven't had a lot of people have a good response. Glycopyrrolate is an oral medication. It's a tablet that you swallow that helps reduce the amount of saliva production by drying out your mouth a bit. I don't use this one very often. I find it's hard to get at some pharmacies. Some people come to me on scopolamine. Scopolamine is a patch that you put on a daily basis. It helps with secretions. It's used in different parts of medicine to help people who accumulate secretions in the mouth. It's also used for what's it called? Sickness when you're on a boat. People with Parkinson's do use it, but it's actually never being studied in Parkinson's disease. And so, though we assume, it may work like the others, it's anticholinergic. There's never been any studies to prove that. There are some adverse effects that are possible with anticholinergic medication. These include delirium, confusion, hallucinations. And so in older individuals who may have dementia or who may have hallucinations, I am quite reluctant to use these medications. I do find that sometimes these medications can exacerbate confusion and hallucinations in people who are at risk for this. I should also point out that these medications, although they've been, the ones in the purple box have been studied in Parkinson's, there have not been many studies, and the studies that have been done have been of very short duration, typically about a week. And so most people who use these medications in Parkinson's don't use them just for a week. They use them long-term for months to years. And so we don't have good data demonstrating their long-term benefit or long-term safety in people with Parkinson's. And there is a question of whether alpha-adrenergic medication help. This is another class of medication and that works on the autonomic nervous system. The data is really minimal, and all the review articles on drooling have been unable to provide any recommendations for using these medications. There are a couple, clonidine and modafinil, that can be used for different purposes, but they may potentially help with drooling. I've never used these medications for this purpose. Clonidine is used more so in the world of tic disorders like Tourette syndrome, and modafinil is used in people with Parkinson's, typically for alertness and people who are quite sleepy during the day. And I've never really had anyone report any change to their drooling, although I've never asked that question specifically, so I may start to do that actually. One thing that people may be aware of is the use of botulinum toxin injections for drooling and Parkinson's. So there are 2 brands of botulinum toxin available in Canada. Most people are familiar with Botox, but there's also another brand called Xeomin. And Xeomin does have some early studies saying that they are as effective as Botox in helping with drooling. Botox and Xeomin are injected into the salivary glands, and they reduce the amount of saliva that's produced. So we know of Botox typically for helping with wrinkles. So in that case, it's injected into muscles to weaken muscles. But in the case of drooling, it's not injected into muscles, it's injected into the glands themselves to reduce salivary secretion. It's generally injected into the parotid glands and sometimes also into the submandibular glands. If it's injected into the submandibular glands, most people use ultrasound when they do it, and that's actually somewhat hard to find someone who knows that technique. Most people I find get an adequate benefit with just the parotid glands. This treatment typically begins to work after about a week and lasts for about 3 to 4 months. 3 to 5 months. I find most people it's around 3 months, unfortunately. Sometimes it can do too good of a job and cause dry mouth, although we never inject the sublingual glands, and again, rarely the submandibular glands. So people do still have glands that are producing saliva. Theoretically, some of the Botox or Xeomin could seep down into the throat and weaken the muscles of swallowing. Studies done on botulinum toxin have really not found this to be a major issue, but it's a theoretical concern. If this were to happen, if someone were to notice that their swallowing worsens after they get injections for drooling, this is also temporary, and it would probably not last more than days to weeks, and probably be more just a sensation of swallowing being a bit more, having a thicker sensation when they swallow rather than having a major issue with swallowing. And again, the studies have not identified this as a major concern. Unfortunately, botulinum toxin injections are not covered by the Ontario Drug Benefit Program. So in people over the age of 65, it can be very challenging to get coverage, and oftentimes people have to have a private drug plan to get it covered. Some people choose to pay out of pocket for this treatment because it's quite effective. There are the benefits of it include the fact that you only need to have it done every 3 to 5 months to have benefit, rather than taking a pill or a drop or a spray multiple times each day. And then also the sprays, pills, drops have the potential for systemic side effects such as confusion and hallucinations, whereas the injections give you more of a local effect without those risks. So some people do pay out of pocket for this treatment $200 to $400 each time, depending on how much they need. For most people, we inject 2 spots in the parotid gland, one kind of near the earlobe and the other near the angle of the jaw. Radiation therapy was investigated as a potential treatment for drooling and Parkinson's. In one study, I think it's out of Montreal, radiation was applied to the parotid gland and the upper parts of the submandibular glands. And they found that after about 1 month, people had a reduction in their salivation, and the effects lasted 1 year. So this may be something that becomes more common over time to pursue radiation therapy for drooling, although there's a lot of time that this takes a lot of time and energy, and I don't know if it would be covered at this point. There are adverse effects. Some people notice a loss of taste or dried mouth after this is done, although these are usually transient side effects. Finally, I'm going to end this with pineapple, question mark. I have a number of patients who really do find that daily ingestion of pineapple to be helpful for drooling. I tried to look into the research on this, and there have not been any studies to state this. I have had other patients tell me that it doesn't help at all, and that they actually find that pineapple is hard to swallow. So it's not for everyone, but there's the theoretical possibility that pineapple breaks down thick secretions, and so this may be why it helps a bit with drooling and with salivation. But it's something to try. It's probably the gentlest thing to try. Just some pineapple juice on a daily basis to see if this helps. So that's something I may consider doing a little study about myself to see if this provides any benefit. And that's it. So I hope everyone learned something from that presentation. I'm happy to take any questions.